virtually. It's really awesome to be able to be here in person. And if anyone at home is having trouble hearing, just let us know and we'll fix that. But I am Christina Montemaro. Thank you, Phil, for the introduction. And I will be talking today about regenerative medicine as it applies to sportsmen in rehab. Okay.
You gotta use them, belt it out.
Yep.
Yep, it's gonna be just shouting.
Slides are not advancing, Phil. There we go.
There we go.
All right, so an overview of what I'll be going over tonight. We'll start with what is regenerative medicine. We'll briefly talk about the pathophysiology of osteoarthritis, since that's one of the more common reasons that we're reaching for regenerative medicine. And then we'll specifically talk about platelet-rich plasma and stem cells. We'll talk about their mechanism of action, their preparation, some different options for preparation of these tools, some evidence for their clinical use, as well as some unanswered questions that we have about how they work and how to use them best. So to start off with, what is regenerative medicine? So by definition, we're talking about the ability to regrow, repair, or replace injured or damaged tissues. And there's many facets to how this can be used, and we'll talk about some of these. To give you an idea of how fast this is growing in veterinary medicine, I pulled just this chart that I know is kind of small to see the details, but from PubMed publications on regenerative medicine, specifically the search veterinary regenerative medicine. And you can see that really in the past 10 years or so, it's gone from being just a handful of papers a year to over 500 every year. And this is specific to, again, veterinary regenerative medicine. If we look specifically at publications in platelet-rich plasma or stem cells, we see a similar trend, but just different numbers, but a very quickly growing field. So no talk about regenerative medicine, platelet-rich plasma, or stem cells is complete without some overview of the pathophysiology of osteoarthritis. And osteoarthritis is one of the most common types of arthritis in our dogs and cats. There are some other types, but OA is far and away the most common. So it can be idiopathic, but more often than not, it's due to something underlying, such as instability, like cranial cruciate ligament rupture, a developmental disease like hip and elbow dysplasia, or trauma. When we're talking about osteoarthritis, often we're diagnosing it based on radiographs, with osteophytes being one of the more common findings that we're identifying. But it's important to remember that there's other joint changes that are happening other than just the development of osteophytes. We have inflammation of the synovium. That synovium in the early stages of OA is going to be developing and increasing production of synovial fluid. So we'll have infusion. Over time, though, we have a decrease in the production of synovial fluid and a change in the viscosity of the synovial fluid as well. We also have initially inflammation of the cartilage, which later becomes cartilage thinning, and that can cause eburnation to the subchondral bone. And then we also do have that formation of osteophytes, but that is a kind of later in the game change that we see in arthritic joints. So as far as how good we are at managing arthritis, we're not really great at it. We, have lots of things to try and manage pain and manage inflammation, but we aren't completely addressing all of these different changes in the joint. So it's important to remember that we have all these things going on. A multimodal approach to treatment is going to be most helpful to try and manage every aspect of this disease as possible. So again, we have all of these different things affecting the joint, and there is kind of an ongoing cycle that's occurring that as there's inflammation of the synovium, we have that increase in different cytokines and growth factors that are pro-inflammatory. those are causing inflammation to other aspects of the joint and causing that cartilage thinning and degradation. And it's just this ongoing cycle that we're not the best at cutting off and actually curing the disease or even early treating the disease. So oftentimes, I'm sure you guys are all presented with patients that come in for lameness. And let's just say it's due to arthritis, it's due specifically to osteoarthritis, whether it's a younger dog that's coming in for hip or elbow dysplasia that we know is going to go on to develop osteoarthritis, or it's a cranial cruciate ligament rupture, that dog is also going to go on to develop osteoarthritis. It's entirely reasonable to think about two options for that patient. Maybe we're going to send them home with a short course of non-steroidal anti-inflammatories and rest, but we may also be considering surgical repair for those dogs. And again, it's important to remember that regardless of what we're doing, hopefully we've improved that lameness at the time that it's occurred, but we're still developing osteoarthritis. It may be several months down the line, several years down the line, but we need to keep that in mind that those patients are going to need additional care, and potentially starting that sooner rather than later would be beneficial. So I wanted to just briefly talk about the multimodal approach to management of osteoarthritis as I see it from my perspective. It's pretty common in the rehab world to have these multifocal assets of treatment. So we'll talk about each one of these very briefly here. So we have our pharmacological means of managing osteoarthritis. Our non-steroidal medications are going to be as the most often used as we can. But certainly we have other analgesic medications like gabapentin and pregabalin that we can reach for additional pain management. Amantadine may be used for chronic wind-up pain, for more chronic conditions that we're treating. We might be reaching for tramadol as a synthetic opioid, although there's questionable efficacy and the mechanism of action in dogs is questioned as to whether they metabolize that as the same as humans for as good of an effect. We have polysulfated glycosaminoglycans, as well as in cats in the United States, we do now have approved anti-nerve growth factor antibodies, and hopefully this will be approved for dogs in the future as well for pain management of osteoarthritis. Weight loss is huge for patients with osteoarthritis. This is one of the most important things that we can do for them. It's also nice for owners. It's free. In fact, it often saves them money because they're spending less on their pet's food. It's been shown that as little as a 6 to 8% weight loss can help to improve lameness. So it doesn't take a lot to make a difference for those patients. Surgery. I think there's somewhat of a misconception sometimes that rehab practitioners are against surgery, and that's by no means the case, at least for me and many of the colleagues that I know. Surgery is definitely a part of management of osteoarthritis. It becomes very clear-cut if we're talking about cranial cruciate ligament rupture. There are some patients that are going to do best with surgical management in addition to all of these other things. But even when we're talking about hip dysplasia, elbow dysplasia, other forms of osteoarthritis, there's definite benefits to surgery for some of those patients, and something that shouldn't be discounted as part of this multimodal approach. We have nutraceuticals. I could spend probably more than an hour talking about nutraceuticals alone, and I've listed some common ones here. I'm not going to talk about them, but I'll just say, if you have one that you like and you are seeing good results, keep using it. Physical rehabilitation. This may involve therapeutic exercises, manual therapies such as massage, soft tissue, and joint mobilization, or hydrotherapy, swimming and underwater treadmill, something that I believe very strongly can benefit our patients. Adjunctive therapies and other considerations. Photobiomodulation or therapeutic laser, often something that we'll employ for patients with osteoarthritis. TENS, or transcutaneous electrical nerve stimulation. This is a form of electrical stimulation that we use for pain relief for these patients. Acupuncture can be helpful for management of pain with osteoarthritis. Assistive devices, such as braces, and then environmental modifications like setting up the home better for that pet using ramps, different slings and devices to help them in the home. And then finally, what we're here to talk about tonight is intra-articular therapy. So there's more than just regenerative medicine as options for intra-articular therapies. We do have corticosteroids, hyaluronic acid, and more. But tonight we'll be focusing on platelet-rich plasma and stem cells. So we'll start off with platelet-rich plasma. So by definition, platelet-rich plasma, or PRP, is a 4 to 7 times concentration of platelets compared to a whole blood sample. Platelet-rich plasma can be either leukocyte-rich or leukocyte-poor, depending on the preparation. And again, by definition, it requires the exclusion of red blood cells. So we don't want red blood cells in that sample. PRP can be either autologous or allogeneic. So autologous coming from our own patient, allogeneic can be from another patient that is in the clinic, or it might be an off-the-shelf product. My slides are no longer advancing.
Oh, I know. I'm sorry. I got kicked off. It's a pain in the rumpus.
We'll just take a brief pause. All right.
You good? Okay, sorry.
So the mechanism of action by which platelet-rich plasma works, you can see this nice figure on the slide showing some of the benefits, and it's primarily working through a variety of different growth factors and cytokines that are creating an anti-inflammatory environment in that joint and promoting tissue healing. So we have PDGF that's promoting angiogenesis, mitogenesis, macrophage activation. I won't read all of these, but that is the most common ones that we're looking at are angiogenesis, having some antimicrobial properties, and promoting fibroblast proliferation for tissue recovery. So there's a couple of different preparation techniques for PRP. There are a number of commercial kits available, and each of these typically come with a dedicated centrifuge for their system, as well as their particular collection system. So their syringes, their special tubes, and each of these are going to give you a variable number of platelet concentration compared to whole blood, as well as other components. So it's important that if you're using a particular commercial kit, that you kind of understand what your kit is able to do and potentially do some in-house testing to see what platelet concentration is it giving me. It's also, the different kits will also use a different amount of whole blood from your patient. So typically anywhere from about 13 mils of blood up to 60 mils of blood might be required from your patient for the different kits. So also important to understand that if you're taking a sample from a very small patient, you might be limited in whatever particular kit you have in your hospital available to you, might not be the best option for your patient. With that, you also have a variable volume of PRP that's created. So typically, if you're taking more blood, you're creating more PRP. And depending on how you're using that, you might have not enough of a sample if you've only taken a small sample of whole blood from that patient. There is also a technique that's been described and validated that does not use a commercial preparation. This is something that can be done with a standard centrifuge in conical centrifuge tubes. So Shin et al. Describes a double centrifugation technique where they take a whole blood sample and use citrate as an anticoagulant and do a first centrifugation at 1000 G for 5 minutes. Then they remove the plasma and spin that down at 1500 G for another 10 or 15 minutes, and then can remove that platelet fraction that is from that sample. This creates about a 6-fold increase in platelets compared to the blood sample. So we are meeting that definition of PRP without having a special commercial kit. There is going to be some variability in that sample. So if PRP is something that you're using with regularity, I do think that there is a benefit in using those commercial kits. But if you're using this sparingly or for a wound care that you don't have a commercial kit available, this is absolutely a possible means of performing PRP. A brief side note, there are other types of products that people will talk about when talking about PRP that don't strictly meet the definition of platelet-rich plasma, but I do think it's important to just briefly touch on them as they might come up in some of the studies that we'll be talking about here. So there's autologous conditioned plasma, or ACP, which is a leukocyte-poor product that does concentrate platelets, but not to the extent of a true PRP product. So typically it's 1.2 times that of what's in whole blood. So the benefit of this product is really more in that leukocyte-poor product that's created, rather than just the platelet concentration itself. There's plasma-rich growth factors, which is a slow spin technique that is similar to how PRP is created, but it allows for a greater separation of those platelet products and other cellular components. So you can kind of tailor the treatment differently depending on what you're using it for. The benefit of this is that it is leukocyte-free, depending on where you're collecting your serum. And it's very rich in different it's rich in platelets if you collect the correct amount, but it is overall lower in platelets than a typical PRP. And then finally, there's autologous conditioned serum, which is a whole blood sample that's been incubated in glass beads and then centrifuged, similar to a PRP product. And this is specifically going to block IL-1 beta, primarily by an IL-1 receptor antagonist. So this is more used on the equine side, but there is growing interest in this in the canine world, so it might be something that you run into in the future more. So we'll talk about a couple of studies that have been done for different disease conditions with platelet-rich plasma, starting with hip osteoarthritis. And a group out of Portugal has done a great job looking at the use of PRP in just the last few years. So this first study that they did was just using a single injection of PRP in a group of police working dogs that all had hip osteoarthritis. And they did not have a control group in this study, but they did find that these dogs had improved CMI, which stands for clinical metrology instruments, or variety of surveys, a variety of veterinary exam findings. They found those effects lasting up to 6 months after that injection. They followed that study with 2 more studies looking at similar type of dogs. So again, working police dogs with hip osteoarthritis. This time they were comparing it to a control group. So this is kind of the best, one of the better forms of research that we can be doing. And they found that these dogs had improved ground reaction forces, so an objective measure of lameness. They had improved range of motion of those hip joints, as well as, again, those surveys and the veterinary exams were improved for, in the one study, 3 to 4 months, and in the other study, up to 6 months. The study that showed improvement up to 6 months, they did 2 injections of PRP versus that first study. So there is some evidence here that potentially a series of 2 injections may provide that added benefit for a longer duration of that efficacy. This one study also looked at radiographs over time with these dogs and found that there was no progression of radiographic findings of OA in the group that received PRP versus the control group did have progression of their osteoarthritis over that 4-month period. So that's pretty exciting from a can we slow the progression of arthritis standpoint. And then finally, one more study that this group did looked at a combination of different medications in different dogs. Again, looking at police working dogs with hip osteoarthritis. They compared platelet-rich plasma to hyaluronic acid, as well as triamcinolone, a steroid, and stanozolol versus control. And they found that the platelet-rich plasma was far and away better for these dogs. And they had improved ground reaction courses, so our objective measure of lameness was improved, as well as those clinical metrology instruments. And that lasted, again, up to 6 months. Now to talk about cranial cruciate ligament rupture and where PRP can fit into this disease process. The first study that was done here was in a transection model of cranial cruciate ligament rupture, so not in a clinical model, but still had some good information for us. It showed that over the course of 3 months after these dogs had transection of their cranial cruciate ligament, they had improved ground reaction forces and range of motion in those joints compared to joints that were not treated with PRP. This has been followed by studies in clinical patients with cranial cruciate ligament rupture. And in this first study here by Lee et al., that's in the middle of the slide, we have a group of dogs that received platelet-rich plasma plus hyaluronic acid at the same time versus dogs that received just hyaluronic acid versus those that did not receive any treatment. And the dogs that received PRP plus hyaluronic acid did the best. They had improved objective lameness scores and improved range of motion for up to 3 to 4 months after that injection. They also had less cartilage damage. So they went in arthroscopically and took histology samples of their cartilage and found less cartilage damage in those dogs that had received the PRP with HA versus HA alone. And then finally, in this last study, most recently, again, we have improved ground reaction forces in dogs that received platelet-rich plasma for between 1 to 3 months. That study it didn't look very long-term in those patients, so we may have had benefit beyond that, but up to 3 months for those. Then some miscellaneous uses of platelet-rich plasma that have been reported in the literature. We have a study of a common calcanean tendon rupture that showed, sorry, that's the second one here, that showed that a common calcanean tendon rupture treated with surgical repair and PRP were having improvements in their limb circumference and the diameter of the common calcanean tendon on ultrasound, with improvement seen at about 8 weeks post-operatively. So good outcomes for those dogs that have had a pretty significant soft tissue injury. And then going back to the first study there, sorry, that's out of order a little bit, but that's looking at dogs that receive platelet-rich plasma for elbow osteoarthritis. And they compared autologous conditioned plasma, so that ACP, versus hyaluronic acid and a steroid, methylprednisolone, and found them to be pretty equivalent, with improved surveys from the owners as well as veterinary findings for up to 6 months. And then this last one here is something just to keep in mind. This group did an in vitro study looking at the effects of PRP given with lidocaine. So lidocaine, we know, does have some cartilage degradation effects, which as a sports medicine practitioner, I might be using or choosing to use a local anesthetic as a joint block. So if I'm working up lameness, I might inject a small amount of a local anesthetic to try and figure out, is this joint the cause of the lameness or not? So lidocaine might not be the best option if I'm going to cause cartilage destruction in a joint that might be normal. But this study showed PRP can prevent that cartilage degradation. And so potentially using both of those at the same time may be beneficial. Another thing to note with that is if you're doing diagnostic analgesia, carbocaine also is less cartilage destructive than lidocaine, so that would be another option. So there are some unanswered questions about the use of platelet-rich plasma in patients. We don't know the optimal platelet concentration and other components in those samples. We do know we want to exclude red blood cells. They are going to be pro-inflammatory to the joint. But do we need to have leukocyte 4 products, or in some cases, would we want some amount of leukocytes, some amount of white blood cells in there? We don't know the answer to that right now. With platelets, typically people are dosing it per volume with between 1 to 3 milliliters injected into a joint. For soft tissues, if we're injecting it intralesional, it's usually 1 milliliter or less. But should we be looking at the number of platelets rather than the total volume? Don't know the answer to that. Frequency, like I said, there's maybe some evidence that that series of 2 or more injections may be beneficial, but we don't know for sure. We only have a very small number of studies looking at this. Platelet activation. So for the most part, the platelets are going to be activated endogenously once we inject the sample. There are ways to activate platelets prior to injection, but we're thinking that this is causing more adverse reactions, typically just a transient lameness, nothing serious, but potentially waiting to activate the platelets, allowing that to happen endogenously would be favorable, but again, something we don't 100% know the answer to at this point. How we collect our whole blood sample. We can draw a sample from a jugular vein if we want to, especially if we're collecting a large volume of blood. That's been shown to have less platelet activation prior to sample preparation. We can also pull it from a cephalic vein or another peripheral vessel, and that's been shown to potentially be able to provide a greater platelet concentration. So pros and cons of both. Don't, again, know what is the best way of doing that, and typically we're deciding it based off of the volume of blood that we need in a particular patient that we're working with. And then finally, oftentimes these patients will be having concurrent rehabilitation therapies, concurrent medication usage. So there is evidence that NSAIDs should be avoided for 1 to 2 weeks after a use of PRP. And this is because platelet-rich plasma is going to have a short-term pro-inflammatory effect after injection, and NSAIDs are going to inhibit that. So we don't want to inhibit the effects of our platelet-rich product by using NSAIDs. Similarly, laser is questionable. Is that okay to use after or not? Because laser is going to have anti-inflammatory properties. Do we want to be inhibiting that transient pro-inflammatory mechanism of the platelets? Shockwave is something that is typically used more for soft tissue injuries, so extracorporeal shockwave therapy. And we may choose to pair treatment with platelet-rich plasma with extracorporeal shockwave therapy. Both of these therapies are going to be initially pro-inflammatory and then down the line anti-inflammatory as their end effect. But what's really unknown about these two together is in what order should we do them? Can they be done the same day? So shockwave has been shown to activate platelets. Going back to should we activate platelets or not, or should we allow it to happen endogenously? Some people will do the shockwave therapy first and then follow that with the platelet injection. Other people do it the other way around to purposefully activate the platelets. And then lastly, cryotherapy, ice. Should we, again, be promoting an anti-inflammatory mechanism by icing, if we actually want the pro-inflammatory effects of the platelet-rich plasma. So this one's kind of hard for me because I want the owners to be able to do something that helps the dog to feel a little better after we've injected them. They're going to be a little bit painful after we've injected a joint or a soft tissue, but I typically recommend that they do not ice the dog and instead enrich it for other types of analgesics if they are painful. So things like gabapentin, potentially that's where I pull out tramadol. All right, and then moving on to mesenchymal stem cells. It's a hot topic for sure. So what are stem cells? These are undifferentiated multipotent cells. They can differentiate forever and into a number of different cell types. So in rehab medicine, I'm really interested in cells being able to differentiate into osteocytes, chondrocytes, everything that we want to grow in a joint or in a soft tissue. They can also become tendon cells, tenocytes. This is something that doesn't happen quite as reliably, but would be really great for our soft tissue injuries if we could promote them to become tenocytes. So stem cells somewhat do go directly into that differentiation phase when we inject it into a tissue. So some amount of those stem cells that are injected may become bone cells, may become ligament and tendon cells. However, that's not the main mechanism of action that mesenchymal stem cells work in a therapeutic setting. It's more similar to the PRP side, where we're having improved angiogenesis, reduced apoptosis of the cells that are present. Mesenchymal stem cells that are injected into a joint or soft tissue will also promote more endogenous stem cells to come to the area, as well as having anti-inflammatory effects and promoting improved white blood cell concentrations in that area as well. So again, that's kind of repeating what I just went over. There's going to be some amount of differentiation into those end target cell types that we have injured in that area. We're going to be recruiting some of the circulating stem cells to the area to do that job, as well as secreting growth factors, anti-inflammatory factors. There's growing evidence that mesenchymal stem cells are synergistic to platelet products, so there is likely an advantage to using both of these at the same time if we're reaching for stem cells. This appears to be concentration dependent. So at concentrations of 80 to 100% ratio of platelet-rich plasma to stem cells on a volume-to-volume basis, there's actually going to be some negative effects on the stem cells versus if we use a lower concentration of platelets, a lower amount of platelets per volume with the stem cells. There's a couple of different ways that we can prepare stem cells for our patients. We can use a cultured autologous preparation, so taking a sample from our patient, typically either adipose derived or bone marrow derived. And for the adipose derived mesenchymal stem cells, typically we're going to be taking a sample of adipose tissue from the scapular region, the inguinal region. We need about 20 grams of fat cells. So for a majority of our pet population, this might not be a problem. But for sporting dogs, it actually is. Sometimes we have to get them to gain a little bit of weight before we have 20 grams of fat that we can collect through a single site. You can also take falciform fat, which tends to be a little bit more available, even in our very lean patients. But now we're talking about a slightly more invasive procedure for a relatively non-invasive treatment option if you compare that to surgery. So kind of pros and cons of that. Bone marrow derived mesenchymal stem cells, that's definitely a little bit more invasive than just taking some fat tissue, but it is an option. Which to use isn't super well defined in dogs. In horses, there is evidence that bone marrow derived mesenchymal stem cells is more efficacious, but in dogs, there's not a huge difference that we can tell, and adipose tissue will give more stem cells per volume. So potentially advantageous if we just want more stem cells to inject. With those culture techniques, it's about a 2 to 3 week turnaround time minimum. You have to collect your sample, send it to a laboratory that will isolate those cells and culture them, and then they send it back to you. The advantage of that is they can bank your sample. So 6 months from now, my patient's ready for another injection. I just call up the company and say, send me my next amount of stem cells, and the next day I have it. I can re-inject that patient without having to repeat that preparation and that collection process to create the stem cells. There are also point of care preparations that would allow us to perform that procedure the same day. Again, we can have adipose-derived samples, and this is called stromal vascular fraction, where we collect adipose tissue and create a stem cell rich product in-house with a special preparation system. This is going to have other things besides just adipose-derived mesenchymal stem cells. There are going to be other endothelial cells and precursors, as well as white blood cells. We can also take a bone marrow sample in this case as well and do bone marrow aspirate concentrate, or BMAC. Prepare that in-house. It's going to have a large number of bone marrow-derived mesenchymal stem cells, but other white blood cells, other precursor cells there as well. Obviously, the disadvantage to this is if we want to repeat an injection with that patient, we have to collect a sample again. And if we're talking about especially bone marrow aspirate concentrate, that's collecting another bone marrow sample, which is a relatively invasive procedure for our patients. So this is something that I think of more for kind of a one and done deal. If we're talking about a patient with a soft tissue injury, or if we're using this in conjunction with a surgical repair and we want to kind of jumpstart that healing process, this is nice because we can do it the same day, but we may not need that additional care down the road. And then finally, there are allogeneic products for mesenchymal stem cells. This may be a donor patient for that individual recipient that you collect at the time that you need it. This is probably not something that is being used frequently clinically because of that potential for an immune reaction to the mesenchymal stem cells, although in a pure product that shouldn't happen. There are also off-the-shelf products that laboratories are using donor animals to create a cultured and clean product that does not have any other types of cells, does not have any potentially negative factors. And again, we shouldn't be seeing an immune reaction to those. So we'll talk about kind of comparing the platelet-rich plasma studies that are out there to what we have on the stem cell side, starting with hip osteoarthritis. So what I've tried to do is list the number of cells that they've used, because this is how stem cells are dosed in the typically millions of stem cells. And when you're using a product, you should know how many cells are available per milliliter. So this first study compared, they used 15 million adipose-derived mesenchymal stem cells and compared this to the stem cells alone versus adding in a PRP product. And they found that, like I was mentioning before, using PRP in conjunction with the adipose-derived stem cells did have a benefit compared to just the stem cells alone. These dogs had improved ground reaction forces, so improved objective lameness measures for up to 6 months. In another study, they used twice as many stem cells, so 30 million, and directly compared the adipose-derived stem cells to PRP. So in this case, not combining the two, but just purely which is better. And this study found that functional improvements were seen up to 6 months, with both groups responding really well. All groups had improvements up to 6 months, but the improvements were slightly better in the group that had received stem cells compared to the PRP. And then finally, one more study that did things a little bit differently. Rather than injecting the stem cells directly into the affected hip joint, they actually injected it into acupuncture points around the hip. So basically intramuscular injections. They compared using a relatively small number of adipose-derived mesenchymal stem cells, so only between 200,000 and 800,000, compared to stromal vascular fractions, so that in-house preparation of adipose-derived mesenchymal stem cells that has some other factors as well. And they found clinical improvements up to 30 days. That's just as far as they looked out. So there might have been improvements beyond that, but up to 30 days with the patients receiving that stromal vascular fraction doing better than those that had received the adipose-derived mesenchymal stem cells. So this is really interesting to me just because this is kind of a less invasive option. We're still having to collect the adipose tissue, but we're not going directly into the joint, and we're still seeing benefits. So that's pretty cool to me. We have a couple studies looking at mesenchymal stem cells for elbow osteoarthritis. In this first study, adipose-derived mesenchymal stem cells were compared when used in conjunction with PRP versus hyaluronic acid, and they used a relatively low number of stem cells for this, only 3 to 5 million. These patients had functional improvements up to 30 days. Again, that's as far as they looked, so we don't know if they had improvements beyond that. This next study is using an allogeneic product of umbilical-derived stem cells. So this is something that is much less studied, but I find this an interesting study nonetheless. They found they were using the Canine Brief Pain Index as a survey to see how these patients responded to these allogeneic umbilical cord-derived stem cells, and found only about a 50% treatment success. But for those patients that did respond, those effects lasted up to 6 months. So the question here is elbow osteoarthritis not as respondent to mesenchymal stem cells? Is it the allogeneic product? Is it the umbilical cord-derived stem cells are not as efficacious? Don't know the answer to that, but to me, a 50% treatment success is not as good as I would like. Cranial cruciate ligament rupture. There's actually a lot more studies looking at stem cells, often combined with platelet-rich plasma, compared to just those with platelet-rich plasma alone. In this first study, they compared in a transection model of cranial cruciate ligament rupture, adipose-derived stem cells given with PRP or those stem cells given alone. They found improvements up to 3 months in the function of those patients, so improved range of motion, improved comfort, and reduced osteoarthritic changes. So this was a study that they looked at histology and found less arthritic changes over the course of those 3 months. They found that the combination of stem cells plus PRP was the best at doing those things. And interestingly, platelet-rich plasma alone was better than the stem cells alone. So together, they worked the best, but head-to-head alone, the PRP was a little bit better. And then this next study, another interesting thing that they did here as far as how they gave the stem cells. In this study, they gave a portion of stem cells intravenously as well as directly into the joint. And they found reduced markers of inflammation when they looked at both systemic markers of inflammation and synovial markers of inflammation. And this was a model that used dogs that had a partial cranial cruciate ligament rupture that they injected into. And of the 11 dogs in this study, 3 of them went on to create a cruciate tear, but the rest remained stable and did very well. This last one is similar, that they were using a model of dogs with partial cranial cruciate ligament rupture, and they used BMAC. So instead of using adipose-derived or bone marrow-derived cultured preparations, they used an in-house sample for some of the dogs, combined that with PRP, and they compared this to an adipose-derived cultured sample of stem cells with PRP. All of the dogs improved. They had better ground reaction forces, so they were less lame. And they went back and did a second look arthroscopy and found that arthroscopically there were improvements to the remaining cranial cruciate ligament rupture. So there was neovascularization, and there was no further tearing in most of the dogs. In this group, 7 of the 36 dogs did go on to have a complete cranial cruciate ligament tear. So some of them still did have further tearing, but a majority did not. And then some soft tissue applications. So going beyond the joint, we have 2 studies that are looking at supraspinatus tendinopathies. So this is a common soft tissue injury of the shoulder. We see it in working dogs a lot, but we also do see it in our pet population. It's something that's pretty challenging to treat. It's often a chronic strain type of injury, and it's very hard to get dogs to stop jumping down on their front legs, and that's what we think is causing it, especially in our pet dogs. These 2 studies showed that using adipose-derived mesenchymal stem cells, or BMAP, plus platelet-rich plasma helped to improve the dog's lameness, as well as ultrasonographic findings of soft tissue injury. So improving the fiber pattern of the ultrasound images, as well as reducing lesion size. And those effects were seen pretty quickly. So in the one study, they were seeing changes as soon as 1.5 months, in the other up to 3 months. So about a 3-month recovery for those dogs, which for a supraspinatus tendinopathy is pretty good. We're often dealing with years of lameness before they bring them into us. So, and then another interesting soft tissue application was in a group of police working dogs that had a semitendinosus injury. So gracilis and semitendinosus myopathy is a soft tissue condition that we see more commonly in German Shepherds, but we can see it in other types of dogs. It creates a very characteristic gait pattern that once you see it once, you'll always know what to look for. And what happens is these dogs have some injury to this muscle that then becomes a fibrotic myopathy. So that tissue, that normal healthy muscle, is replaced by scar tissue. And historically, we've not been able to treat this. People have tried surgical removal of the scar tissue. It grows back. Aggressive rehabilitation may help with pain management and function with these dogs, but does not fix the problem. This study looked at using adipose-derived mesenchymal stem cells and injecting that directly into the muscle injury. They found in all of these dogs that they had an improvement of their lameness, with many of the dogs' lamenesses resolving. The ultrasound findings of scar tissue that had been forming early on when these dogs were looked at resolved. And this was happening very quickly. So within a couple of weeks, they were seeing improvements. And those improvements were long lasting. So at 6 and 12 months, these dogs, like I said, they were police dogs, they were back at work and not having recurrence of lameness, which is pretty remarkable. This is just one study looking at this, so we'd love to see more in our pet dog population or in other working dogs. But something that I think is really exciting for me, because I see these patients and I cringe because there's previously not been a lot that I can do for them. So we have some remaining questions with stem cells, just like we did with platelet-rich plasma. When we're comparing the two head-to-head, there is a huge cost difference. So we have to weigh that cost difference with the benefits. Both therapies have been shown to be effective for our main arthritic joints, as well as some of those soft tissue injuries that we might be choosing to use them for. But is the benefit of stem cells, which has been shown to be more efficacious in some of those cases versus PRP alone, does that benefit make the cost difference worth it? It's one of those things that you have to kind of think about what you're treating, what other things are going on with the patient to make that decision. Optimal source of stem cells, like I said, typically we're looking at adipose-derived or bone marrow-derived mesenchymal stem cells. We do also have that umbilical cord-derived option. Which of those is best as far as efficacy of the treatment, as well as morbidity to the patient? So we don't want to be causing morbidity to the patient through our collection technique that then outweighs the benefit of that treatment. We also have our allogeneic sources. So if we can get stem cells from not our patient, that completely eliminates the morbidity of the collection technique. Is that just as efficacious? Don't know the answer to that fully yet. Optimal dosing and frequency of administration. So like I said, dosing is kind of all over the board. Some studies looking at a couple 100,000, others looking at 30 to 50 million. It seems like if you look at a collective of factors, that optimal dose is probably in the millions, somewhere between 5 and 50 million. But we don't know for sure. And it depends on what product we're using, if we're using adipose-derived versus bone marrow-derived, a cultured technique versus an in-house technique. Frequency of administration, typically just because of cost alone, these injections are more frequently recommended as needed. So we do the first injection, we wait to see how that patient responds, and then as the efficacy of that injection wears off, we might repeat it. But would potentially a series of injections be most beneficial? That first injection gets that inflammation down, the second injection comes in and starts to build those factors from the stem cells themselves to build healthier tissue. And similar to with the PRP, we also have to question our use of medications as well as other rehabilitation techniques. So stem cells, much more clearly than for platelet-rich plasma, should not be used in conjunction with NSAIDs after the treatment. So in some studies, non-steroidals have been shown to improve the stem cell product if that is given at the time of the collection of the tissue that we then use to develop into stem cells. But we don't want to be using NSAIDs after the injection of stem cells for therapeutic use. Those NSAIDs can inhibit some of those stem cell factors. Laser, for those of you that are familiar with laser, we have different classes of laser. So most commonly, therapeutically, we're using class 3B and class 4 lasers. There's evidence that we should avoid using a class 4 laser after a stem cell injection for about 2 weeks. But class 3B lasers might be okay. So there's lots of nuances here. If in doubt, just don't do it. Shockwave, extracorporeal shockwave therapy. No one has looked at this, so someone should, but we just don't know right now if it's okay to use shockwave concurrently with stem cells or if there might be some inhibitory effects there. And then cryotherapy. I think that there's less evidence against using ice for our patients that have just received stem cell injections compared to those that have just received PRP. But if you can manage pain with other oral analgesics, that might be better. We're spending a lot of money and a lot of time to have the most effective treatments when we're using stem cells. So avoiding some of these potentially conflicting treatments might be beneficial.